And now we move down the alphabet to the next virus that was described for viral hepatitis, hepatitis C. And again, we're very fortunate to have Dr. Hugo Vargas with us, who's truly a thought leader in the hepatitis C world. Dr. Vargas did his medical school in Philadelphia at Drexel University. He then crossed the country and did residency at the University of Utah in internal medicine, went back to the East Coast and did a fellowship in gastroenterology at the University of Pittsburgh, which, as many of you know, is also a very large transplant center. And then we're very fortunate at Mayo that Dr. Vargas came to Mayo Clinic, Arizona, where he now has a very active hepatology practice with a large component of liver transplantation in his practice. He is an expert in viral hepatitis as well as end-stage liver disease and cirrhosis and transplantation. And Dr. Vargas's fun fact is that he is fluent in English and Spanish, which I'm sure is very convenient throughout the entire United States. So we'll invite Dr. Vargas to the podium to talk to us about hepatitis C infection.
Well, thank you all for being here. As you can see here, this is me in my usual uniform, not today. And thank you very much for the invitation. I love to see you all here in one of my favorite places in the world to be, in Hawaii. What I want to do is really leave you with an update on a very rapidly changing field. It's been truly exciting to be working with hepatitis C recently because it's really changed. And I just want to sort of highlight some of the present challenges that we have, and then to sort of bring you up to speed on what we are seeing as far as the durability of therapy and what the translation of what happens in clinical trials is looking like in the real world. And then probably update you, but perhaps it's the wrong audience since you're an ID, on new populations who are likely to need to be screened and to receive care in the future. So let me start with a case. This is a 54-year-old man referred to you by his primary care because of hepatitis C infection. You know already he has genotype 1A. He is a police officer, was a medic during his military service, and he has a history of hypertension, doesn't consume any alcohol. His physical exam is unremarkable. As you see here, no evidence of advanced liver disease. His laboratory evaluation is, as you see here, with normal synthetic function, abnormal injury markers. Creatinine is within normal range. For those of you who don't use transient elastography, this is a stage 1 fibrosis, 5.8 kilopascals. And he's HIV negative. His hepatitis B markers are as follows: surface antigen positive, E antigen negative, hepatitis B DNA 6,000 international units. So my question to you is, the best